Okay, just going to check everybody could hear me. Could I get a thumbs up from the panel who I can see? Excellent, thank you very much. I think we'll make a start now. Thank you so much, everybody, coming today to our Virtual Wards in Action, Strategies for Successful Implementation and Optimisation. This is the second in a series of webinars around virtual wards. The first one was hosted around a month ago by NHS Confed to launch the report that we worked on Confed with, which was realising the potential of virtual wards. It was a really insightful session with an excellent panel, and in it we talked a lot about the ambitions for virtual wards, some of the challenges and barriers that we've seen, but also the importance of things like clinical enthusiasm in order to drive it forward. So today we're going to look at slightly different. We've got virtual wards in action, and again we've got a panel with a lot of experience in this space, and we're hoping to give you sort of some actual tips to take away and what's worked previously. A little bit about Acacium Group and why we're hosting this webinar today. So my name's Alex Ryan, I'm the Director of Service Development, and Acacium Group is a delivery partner to healthcare and life sciences sectors globally. So our heritage is in workforce. We do have a large workforce capability. So every week we place around 30,000 candidates. But also we're always looking at ways that we can take that workforce and use it in more innovative and I suppose useful ways and move into services. So we do run a lot of services, and over the past couple of years we've specifically been looking at virtual services. We now run things like teledermatology, digital outpatients. We deliver remote mental health therapies to the NHS. So we're acutely aware of some of the challenges around delivering virtual wards, things like workforce. So that sits neatly with us, but also we can support in that service wrap as well. So that's why we're interested. That's why we're hosting the webinar today. I'm going to pass you over just to the panel for them to introduce themselves very briefly, and then I'll just do a quick overview of what we're going to cover today. So Gurnak, shall I start with you, please?
Yeah, thank you very much. It's an absolute honour to be here and joining the rest of the panel. So my name is Gurnak Dosanjh. I'm a GP from Leicester. I'm also the ICB clinical lead for two collaboratives. One is Home First, which covers the virtual ward programme, and I'm also the virtual care advisor to Acacium Group. Lovely to be here.
Thank you. Eleanor?
I'm hoping you're able to hear me, because
we can
hear me. That's great. Can you see me as well?
Yes.
Great. Apologies. I'm having real problems with Wi-Fi this morning down in Devon. So I'm Eleanor Rollison. I'm a partner from Channel 3 Consulting. We're a specialist digital health and care consultancy, and we're passionate about the transformation that can be achieved in health and care services through digital. And the reason we're here today is because we've supported a number of organisations in implementing virtual wards. And in fact, that's why I'm here in Devon today, is because we're working with the Devon system around how they can use virtual wards, virtual hospital and virtual care to transform the way that care is delivered.
Fabulous, thank you. Scott?
Thank you, Alex, and afternoon everyone. My name's Scott Thornton. I'm the virtual ward and virtual care lead within BT Health. Maybe some slight confusion as to why BT is in this space. We have an ambition to be a trusted, innovative technology and strategic partner to the NHS, bringing the best of BT's expertise across innovation, communication, technology. I'm former NHS, so 10 years in digital transformation and led on the West Midlands virtual ward and virtual care deployment.
Thank you. And then Stephen, last but by no means least.
Hi, Stephen Coleman. I'm Chief Executive at Norfolk Community Health and Care Trust. So we are in the process of, well on with setting up a virtual ward within community services, but we also take a lead on the procurement technology for Norfolk and Waveney as a system. So probably two angles that I'll look to cover. One is from an ICB, how we work across acute and community, but also the kind of size and scale that we're aiming for in community services, using virtual wards as a bit of a lever for that.
Brilliant, thank you. What we will do is I'm just going to give you a little bit of an overview about what we're going to cover today. So we've tried to pick up some themes that will be familiar to some of you talking about virtual wards, but also some that may be a little less developed. So we're going to talk about system scalability, role of centralised hubs, importance of clinical leadership, the role of estates, which doesn't always come up, patient education, potentially linked to public opinion and what the narrative is there around virtual care, how to optimise your current system, and then how you can sort of improve virtual ward adoption in the future. There is a Q&A function, which we invite you to drop your questions in, and we'll either take them as we're going if they're particularly pertinent to conversation, or we'll have some time at the end to do some Q&A. So in terms of system scalability, Stephen, so one of the reasons we were really keen to get you on today is that Norfolk is working, isn't it? So could you perhaps tell us a little bit about how you've achieved that?
Yeah, so there's a number of strands that come together, and I wouldn't claim by any means that it's been down to us at the trust or others. So just to give a bit of background, we've got 3 acutes, Norfolk and Norwich, Queen Elizabeth and the Paget, and then there's 2 community providers. So Norfolk and Norwich as an acute was well on with its virtual ward, and I think had it really well established. The other 2 were in slightly different positions. And as a community trust, just as a bit of background, we were coming from a relatively low base, but have accelerated, I think, quickly once we've got the things in. But I think what's been important for us is we were already doing a redesign around our community services, and particularly our unplanned services. So Norfolk and Waveney as a system had a number of CCGs, relatively small, came together as an ICB. So our admission avoidance pitch, if you like, I would say was very crowded, very confusing, very difficult to navigate because depending on where you were in the county. So one of the things we've enabled this to do is to clear that a bit. And the other big thing is then where does technology come in? And obviously we took a lot of the learning from Norfolk and Norwich, but also from other community services around frailty pathways, heart failure, and where technology can really enable you to meet the pathway. So it wasn't just a virtual ward service, it was how it spanned across. So we see this as the start of that, really, rather than it's not just implementing a virtual ward and we stop there. We've kind of really gone at it with an ambition that it opens up probably most of our community services as you would know them, nursing and therapy as well. So that's the level of ambition we've kind of set there.
Excellent. And Gernak, how about in your system? How have you thought about system scalability? Same experience as Stephen?
Yeah, I think certainly some similar thematics that are coming out. To perhaps give some context, Leicester slightly different in that we have 1 major acute trust, 1 community provider. So in terms of different stakeholders to work within the system, it's perhaps been less challenging in that there's perhaps not been so many different stakeholders that you have to engage with. But that's not to say that there hasn't still been challenges. In Leicester, we had a very ambitious programme and were perhaps a bit more disease specific in our approach. So going for up to 14 different clinical pathways, supporting patients right from the range from kind of heart conditions, from atrial fibrillation, all the way through to things like palliative care. And I think the key thing for us that we perhaps learn is to not underestimate the importance of the workforce within that. And so from thinking about a scalability perspective, the first thing is to make sure that we are working where the energy is. So, identifying the individuals where, the desire to kind of change, move forward and do things innovatively certainly breaks down one of the barriers. But the second thing in terms of kind of system scalability is looking at how we can actually have the workforce in place to continue to scale up. And I think that's been a real eye-opener because at times it's been difficult to recruit the right type of clinical team to man the individual virtual wards. And then the challenge then is as we want to scale up and we want to go from 15, 20 virtual beds to 40 or 50 virtual beds, how do we then get the workforce to man those specific virtual wards? So that's probably been one of the challenges and one of the things that we've certainly learned when we're looking at system scalability.
Yeah, and I think if you look at the report, and if anybody hasn't read the report, I would encourage you to do so. That workforce challenge is certainly highlighted front and centre about one of the scalability challenges. I think it's interesting what you're saying about who wants to do it. I know, Stephen, when we've spoken before, you've had this "you work with the willing" phrase, which I think that really resonated with me. Scott, system scalability. This has got to be something that BT is is all over, isn't it?
Yes, absolutely. And I think I've been trying to drive for this level of change around virtual ward, virtual care, and the use of this type of technology for the last 10 years. The remote monitoring technology is both an enabler, but also a driver for change across the healthcare system. You've mentioned the kind of workforce challenges that we're facing and the increasing long-term conditions. It's the usual rhetoric that we hear around the pressures that the NHS is going to be facing now and way into the future. So we need technology as an enabler to be a positive disruptor to the traditional models of healthcare delivery. I think virtual ward, it is flavour of the month, but for me, it's just the tip of the iceberg. I would see virtual wards as an anchor, but it's only one anchor. There's probably a couple that you can use. For me, the exciting bit around scalability is what do you begin to overlay? How do we transition from virtual ward to virtual care? How do we then hit the more sticky end of the spectrum, which is around self-management of long-term conditions and prevention, with that being the ultimate goal. I think there's some really exciting stuff that you can do off the back of this technology, but at the end of the day, it is just technology, so it needs to be considered around people, process, the workforce. It is a dramatic shift. We'll be obviously looking later around patients who equally have a key and pivotal role to play in the adoption and use of this as well.
Thank you. Centralised hubs. This is one that sort of comes up, and I think again a bit like virtual wards, different meanings in different systems. What is a centralised hub? So, Gernak, have you got any experience in this space?
Yeah, and interestingly, it came outside of the virtual ward model. In Leicester, we have what is called an unscheduled care coordination hub, which is a co-located multidisciplinary team which supports all avenues of unscheduled care and moving it towards scheduled care. And it's had fantastic clinical outcomes for our system, including reducing ambulance conveyances and ambulance wait times and transfer times. So I think it's really important to now start to think about some of the things we've just mentioned. So Stephen quite rightly mentioned, and Scott quite rightly mentioned, that virtual wards are really the tip of the iceberg. You know, this is where we're starting, and what we need to start moving towards is thinking about how virtual wards can offer much broader care for our populations, including those individuals who might not necessarily need to be in a hospital. They might have quite low healthcare demands, or they might actually have social care needs and social care demands. And what that means is that we probably don't need clinical specialists in a particular field looking after or monitoring all of those types of patients. And what that means is we should actually be starting to think about how can we engage with a multidisciplinary team supporting multiple different types of patients. And I often try to refer to them almost as like buckets of care. Within kind of like a red, amber, and green setting, with red people or individuals who sit in the red category need a high level of care, whereas those in perhaps the green category need a much lower level of care. And I think when we're thinking about scaling up, we probably have to start recognizing that things like estates, things like workforce is going to be a barrier for us to try and navigate. So it only makes sense to try and pool our resource, especially when we're looking at very similar metrics, to try and at least identify those individuals who do then need to move up the stages into that specialist level of care. And I certainly think that that approach of using a centralised hub model would probably be the only way that we can actually demonstrate this and scale it up going forward. And that's not to say that we're not going to still need those very specific and specialised models. I think we're going to need to start exploring hybrid solutions as we move forward, though.
Thanks, Gernak. Stephen, I'm going to come to you just briefly to talk about centralised hubs, but Scott, I don't know if you've got any thoughts on what Gernak's just said.
Yeah, absolutely. I think as we move to kind of ICBs and try to reduce the level of fragmentation across the system, and then we've got a technology layer which allows you to manage or remotely monitor multiple patients at any given time, you create an opportunity to start looking at step up and step down and actually trying to manage the flow across the system in a centralised manner. There's always been a part of me which is non-clinical, clinicians undertaking non-clinical activity, so around patient activation, education on technology. Have we got the balance right in terms of clinical activity versus welfare support, especially from a district nursing perspective? And how do you potentially rebalance that by using not even NHS workforce, alternative workforces, in order to be able to do the welfare check-in, leaving the clinical activity being hyper-focused? Not saying that you take that away, because it still has to be very personalised. But if it's a 30-minute call and 20 minutes of that from a clinician is all based around how's the cat, how's the dog, have you had a biscuit today? A lot of that could be taken and be routed back into the system to drive efficiencies, especially given the workforce pressures and the productivity that we need to drive. How do we really streamline all of that? And then I guess the final bit to say on centralized hub is, and it's probably I shouldn't really say this, so don't repeat it, but the less exciting side on BT around contact centers. And traditionally, healthcare is probably about 10 years behind in terms of the adoption of certain technologies which we see in industry. So the likes of AI and chatbots and self-service and automation into contact centers. Are we really optimizing that so patients are actually getting to the right place at the right time, speaking to the right individual, getting the correct information that they need to make the decisions that best suit them? I think there's plenty of work that can be done that can really drive efficiency and productivity and improve the patient experience of care.
Brilliant. Stephen, I could see you nodding along there.
Yeah, I think to build on that, just a couple of other reflections from me. So I think one is around, I guess it's the use of language. So as we've started to get into it, particularly with community services, there's a danger that the term hub actually became a bit of a barrier, because they were all meaning different things to different people depending on the setting you were in. So we had, as Gernak was saying, we were looking at those unscheduled care hubs, but there's also discharge hubs, and there's hubs that teams have. I mean, I kind of think hubs is becoming the new single point of access, and I'm sure there's people on the call of when you ask people, is it a single point of access? And yet every service has got a single point of access, so by definition it's not. So I think we've had to do, and we still, I wouldn't say we've got it right, we are still unpicking a lot of that. I think the other bit that then drives is, and we were having a conversation beforehand from the trust with Eleanor about the work she's doing in Devon, is where's your system ambition and where do you see some of this as opposed to place? Because again, I would talk about Norfolk, we had 5 CCG, so each of them had tried to create one, and now we've got the opportunity to really scale that up. And I just completely agree with Scott around the things such as when you look at a lot of the transaction or the interactions, the use of AI, but that sort of thing is, I think, potentially really game changing. I don't think we've really got I think we've got it in pockets, but again, we could really do some really different stuff there, and we've got to kind of get our heads around that. And a lot of that doesn't need to take place in a locality. I know we're going to talk about the clinical leadership and the clinical buy, but I think that's going to be the bigger challenge with that, is that feeling, certainly for us in a community service, of that can happen somewhere really separate to you, but there's still an interaction with you to drive what you need to do clinically.
Interesting. Thank you, Stephen. So I think that quite neatly moves us on to clinical leadership. Eleanor, I'm going to hope that your Wi-Fi holds.
Yeah, me too.
I'd be useful just to share some of your learnings from some of the work that you've been doing around that clinical leadership piece and how important that is.
Yeah, and I think the phrases of, Gernak came up with, working with those where the energy is, and also Stephen about working with the willing. Absolutely, they're the catchphrases. We're really lucky working in Devon at the moment. The clinicians in Devon are so switched on, and that's not just the medics, that's the nurses, the AHPs, and out into community as well. We've got some real passionate clinicians in Devon, which makes the conversation a whole lot easier. And their level of ambition is really high, and their confidence and desire to embrace the change is also it's infectious, and it pervades the rest of the system. I think it's really important to recognise, though, that some of the resistance that may come from the clinical workforce is around the change in role. So I reflected, I started off my career as a podiatrist, and my training did not equip me for life as a podiatrist in the NHS. I went from treating 2 patients a day in training to 8 patients on a list. when I ended up in the NHS. And I think that the same is true now. We need to make sure that the training is right for the clinical workforce, for them to realise that the job that they're doing now and today will be very different next year, will be even more different in 5 years. So we do need to think about, you know, that flexible ways of working, because I think the driver for this is actually going to come from patients. On the NHS 75th anniversary, a lot of the headlines and a lot of the news coverage was around all the exciting things that digital was going to do in health and care services beyond virtual wards and virtual care. So I think there's going to be a real pull from the population really to drive forward, because they don't really want to be in hospital, you know, want to be cared for at home. And so some of that resistance around the clinical workforce, or perceived resistance, I would say, around the clinical workforce, we need to understand what's behind that and to work with the willing, you know, work where there's the energy, and to drive that change forward.
Thank you, Eleanor. And as this webinar is on strategies for successful implementation, Stephen, that clinical leadership, how have you ensured that you found the right people and helped them use them to affect change?
So I think some of that is the narrative, but the other is, I think, as Eleanor said, that there are a lot that can see the potential, and once you start working with them and they start affecting some of the changing pathways, it has an infectious kind of effect across the trust. And the other bit, particularly for community, I can talk for community services because they're the ones that I'm closer to, and when I've done a lot of, you know, when I've shadowed and been out with them. So we have a workforce challenge that we know we're not going to be able to kind of suddenly magic and grow. So they're dealing with this big caseload that they're naturally worried about. And as you start layering things in, they see that as a solution. It becomes much more kind of like they'll want to work with that because it helps them. It's like stratifying your caseload. It's like some of the stuff that we've been talking about. So I think it's getting that. And then the big thing for me was getting clinician to clinician. So it was, we might have started it off, but when the clinicians are talking to clinicians about how it works, that was a real kind of, starts to be a game changer in terms of, you know, they'll have much more honest conversations. They'll work through some of the practicalities of it, of when it does work and when it doesn't work, and then we can respond to that in terms of what we do as a trust. So I think that working through what their problems are and where they can see it, because I think the danger is you get people who are experts in digital and can understand what something does to 100%, kind of go off, and then the clinician behind it just becomes too hard for them. They can't see it, so they just kind of almost disengage from it. Or the pathway digital is an extra add-on to it rather than it fundamentally changes, and they understand how that's helping them with their caseload.
Excellent. Gernak, anything additional or different, or are you just sort of nodding along in agreement because that's exactly what you're seeing?
Yeah, no, I agree, but I think I'm just gonna, I mean, obviously thinking about strategies, I'm just gonna go maybe one step further and just talk about the importance of recognizing that real challenge of culture shift at the coalface, and how easy it is for clinical colleagues to who are already burnt out and who are already having low morale, to feel that this is yet another thing that is being done onto them and they're being asked to do. So I think, and I talk about this a lot, I think the importance of compassionate leadership cannot be understated. You know, having open ears and being willing to listen to ideas and being willing to listen to challenges, and not being afraid to put the brakes on if things aren't going to plan, I think is also incredibly important in building that confidence amongst your clinical colleagues. And I think finally, it's sometimes it's just about taking that step. Sometimes we strive for perfection, and actually sometimes we have to recognize that this is going to be an iterative approach, and it might take multiple steps to get it right. But if you've got the right level of leadership, and by that leadership, I don't mean the people who are sitting at the top. I mean the people who are at the coalface. They are also leaders. You know, the people who are listening in on this, you're all leaders, and you're all going to be part of that culture change. But by being able to recognise that it's going to take time and being willing to that is incredibly important, in my opinion.
Thanks, Gernak. And I think one of the challenges that's come up in the report in the first webinar was around initially sort of the virtual ward guidance being really prescriptive on the pathways, which meant that you potentially didn't have the opportunity to work with the willing in the same way, because they had to be on the frailty pathway. And actually, I think, you know, if you listen to the news, what you've been hearing this week is around sort of success in pediatrics and things like that. So sort of new pathways again. So I think perhaps, you know, I say the system's taking more responsibility and finding those clinical leads has probably enabled more adoption than perhaps if people had been such more rigid original guidance. So that's really helpful. I'm really interested in this next bit, the role of estates, because I don't think I've you know, we've hosted roundtables of virtual wards, we've had a few discussions, and it doesn't really come up in the same way that a lot of the other topics do, because, you know, they're virtual, so you don't need estates, right? But probably not. So Eleanor, again, perhaps some of your experience would be useful here.
Absolutely. So this is in implementing virtual wards and virtual care and digitally enabled care pathways. The pathways are obviously going to change, and the way that you deliver that care is going to change. And what's important is that then the estate needs to change then with it. So if you think about moving from having community nurses out on the road looking after patients, and actually we then move to a hub environment where we've got a command centre, you need to have a facility there that enables you've got good Wi-Fi connection so that systems don't fall down. But also that you've got an environment in which multidisciplinary teams can look after patients in a digital, you know, through the screen, which requires a very different building. It's not like having a consulting room or an outpatient area. You need a very different estate. So there's real opportunities actually. So the reason this has come up as important for us is we're doing a piece of work at the moment around digital asset optimisation, which is a bit of a consultancy speak title, but it's basically using the digital assets that you've got, which includes virtual wards. How can you optimise the impacts of that technology in order to be able to release financial efficiencies and also performance improvement? Because, you know, we've got to get the NHS back on its feet again. And as a result of that, we've been looking at how digital asset optimisation can impact cost improvement programmes, and estates are the key part of that. Now, there'll need to be some investment in new estate to facilitate and support those new ways of working. But also, if you've got less of a footfall of patients actually coming into a hospital environment for outpatient appointments or for inpatients, then you need less of an acute footprint. But you do need to make sure that you provide the estate back in the environment that then supports the new ways of working. So it's around efficiencies, and this is only going to happen when we implement virtual care at scale. So I think one of the issues we've got at the moment is more pilots than Ryanair is the saying that people are coming out with. But it's true, we've got so many pilots, and it's really important, as we started off, you know, to talk about scaling. And if we do implement virtual care at scale, it will have that impact on estates that we'll need to then respond to.
That's really helpful. Thank you. I'm going to just pluck one question from the Q&As, which might be for you, might be for Scott, probably also for Stephen and Gernot. How do you engage with individuals who are anti-technology, who you know would benefit from a virtual ward offer? So I think with clinicians, you've got the hook of the patient care and outcomes. What about the people who need to embrace a technology solution that perhaps was already there? How do you engage? And yeah, so it might be you, it might be Scott, might be both of you. So should we bring in Scott first, and then Eleanor, I'll come back to you.
Yeah.
Happy to jump in, because it actually aligns to a point I was going to make around clinical leadership. I think the relationship between technology partners and innovators and the NHS has changed over time. I think previously it was let's build this in the garden shed and then push it onto healthcare, and then all of a sudden they were surprised that it didn't quite work. I think there's more of a narrative and conversation and co-creation approach around how technology is actually built and designed to ease the implementation process. And many of the innovators from my time at the AHSN were very much driven by this kind of people first, technology second, because we've got such a terrible habit of overlaying bad technology, well, good technology on bad process, and then sit there wondering why we've duplicated effort rather than kind of achieve the efficiency gains. So I think all of that probably goes back to the design process. And if you get the design process right, you should be addressing a lot of the issues around those that are technology savvy and those that are not. But the reality is, most clinicians, NHS staff, in their personal lives, they'll be using mobile banking. they were using online shopping. You know, they're familiar with these types of technologies, and then they come to work and may well be using archaic systems. The same process should apply in healthcare as you would do from a retail perspective, as an example.
Brilliant, thank you. Eleanor, anything different?
Yeah.
Or
So I think for now, we will always have to have a dual running for people who do not embrace technology, or for which the infrastructure isn't there for them to be able to use it, you know, perhaps down in rural parts of Devon where there's no Wi-Fi. So I think for now, we will always have to have that double service running. But as Scott said, you know, we're all digital now. The digital revolution in healthcare is happening now, and the demand is being driven by patients. My mum and dad, you know, want to have their consultations online. They don't want to have the hassle of driving to hospital and having to park and pay the parking costs. And they're in their 80s. So, you know, the push is going to come from patients. We need to make sure that we have then that parallel service. And yeah, but the revolution is happening, as has happened in banking, as has happened in travel, and has happened in retail.
excellent, the revolution is on its way. Good to hear. Stephen, estates, how did you think about estates in your virtual ward rollout?
Well, I think it built. I think there's if I can just go back, I think there's a really important bit that we've been trying to think through in terms of that. How do you engage with people as well? And I guess while we are where we are, the other bit we're really mindful of is kind of not driving a digital inequality. So there is an infrastructure bit, but I think we've been really mindful as well. So we've had it in physical appointments as well, where people have been reluctant to travel and do whatever because of kind of cost of living issues that they've had, but that also applies to digital. So we just need to, I think, as we run through both, it will transition. But I think that's an important one that we shouldn't, and we've got to be really cognizant of as we develop the services. I think in terms of estate, I would just build on what people said. I think it was kind of a bit of an afterthought, and actually it was really important about what's the environment, has it got the infrastructure to run, and has it got can we scale it up as we keep progressing with this? So I think they're the things that we're thinking through. The other bit we're doing as a trust, I wouldn't say for the system, is we are now thinking through this year about what that could potentially really unlock for us in terms of efficiencies in estate. Being a community trust, we have probably 50, 60 sites across there. We could really do something different, and that will naturally give us an efficiency that we can then use back into services. So that's kind of the journey that we're on, that we're thinking about.
Excellent. And then Scott, I think we brought you in on challenge technology. Did you have anything else specifically around estates?
So I've probably lost count of the number of times in my NHS career that I've walked past a 50-inch screen with loads of lovely data that everyone kind of popped the banners up as soon as it was turned on, and then just walks past it like a piece of artwork for the next 10, 15 years. And the key point for me is, from a clinical perspective, they make decisions on objective data and best judgment. If we're not using objective data from an operational perspective, I would personally not feel confident making operational decisions, because at the back end of that decision will be a patient. So for me, there's an opportunity around virtual boards around extending that kind of objective data view, because if we're always working off objective, validated data, we can start making informed decisions, and that involves understanding the process behind. And going back to Eleanor's point, it is the command center piece. How do you look at IoT and patient flow in an acute, and then how do you look at virtual ward and virtual care in numbers in the community, and how does that then give you an overall perspective on capacity and demand at a system level and what needs to change? You can start making bigger, more reliable decisions when you're using objective data, and then you can start doing some really complicated stuff over the back of that, but keep the same premise. It has to be objective, otherwise no one will make a decision that they would want to put their job on the line for.
Well, bigger, more reliable decisions sounds like something that we're going to need for successful implementation and optimization of virtual wards. So that's really useful. Patient education. This has come up. It came up, touched on it in the first webinar, but I was at a roundtable the other day where patient education and narrative and public opinion, I suppose there's a need to shift that potentially in the same way that Eleanor was saying, as a, you know, when she was training, she wasn't training to work in a virtual ward environment. Obviously, that's not how patients think care. All patients think care should be provided. So, Scott, I don't know if you've got any thoughts on this patient education piece.
Yeah, so I think we're still very much operating a paternalistic model of care, and how do we drive greater empowerment amongst patients to be able to make better and more informed decisions. Even if we take the narrative around virtual ward and virtual care, I still wouldn't say for those that are outside of healthcare and outside of technology that it's common parlance and they truly understand what it is, what it means, and what the benefits are. But there are opportunities, and they're small. They can be as small as sending a simple, smart, personalized message or an SMS message at the right point in the pathway before someone even gets into an acute setting where they're fully informed as to their options. So one of the challenges around virtual ward is it's because it's relatively new. It works on a pull model rather than a push model, and you have teams going in to identify and pull patients out that are appropriate for a virtual ward, whereas a much stronger narrative would be the patient driving the clinician to say, I want to be home. I don't want to be in this bed. I want to be with my dog. Now you can front load all of that education from the very point at which they start to be diagnosed with a long-term condition. So by the time they do end up in the queue, which will inevitably happen, they know what their choices and their options are.
So that's relying on everybody having the same narrative and same message. But I suppose, Gernak, is there, that's once you're a patient, or once you're in a clinical setting. I suppose is it wider than that? Is there another a role elsewhere of educating the patient before they become a patient?
Yeah, I think absolutely, and if it's okay, I just want to backpedal a little bit actually, because we spoke a little bit about the importance of recognizing that, you know, if we're going to scale this up, we need to move to a centralized type model. Now, there's a big challenge with this. The elephant in the room is always going to be, well, that isn't my doctor, or that isn't my healthcare team, that isn't my hospital. So, you know, there is no reason why we can't have a centralized team in London looking after patients who are in Leicester. You know, we've got the technology to do it, bearing in mind, obviously, the digital inequalities perspective. And Stephen quite rightly hit on a point there. We don't want to create another digital silo or another health inequality silo. There will always be patients who will need the kind of the non-virtual approach to care. And there will always be individuals who are perhaps either fearful of the digital technology or have got other reasons why they can't engage with it at this point in time. And we can work towards that. But there's no reason why we can't have you know, teams working across England to really bring this to scale. The problem is the perception from the general public then about how they receive healthcare. And I think there's some really simple things that we can start to do. The first thing Scott's really alluded to is that often the first time that people hear about virtual care, virtual wards, virtual technology is at the point of need. So you basically identified a patient when they are at their, probably at the lowest in their disease trajectory, or already feeling very anxious and insecure about what is coming. And you're then saying to them, right, we're going to send you home. Whereas the narrative, certainly over the last, as long as I've been in healthcare, has always been that the big shiny building is the place to be when you're unwell. But actually, we now know that's not true. If we look at some of the stats, you know, much lower rates of hospital-acquired infections, much lower rates of muscle mass loss, and the ability to maintain yourself in the comfort of your own home, having your own food and sleeping through the night without someone badgering you for a blood pressure or a temperature check. You know, these are all things that we perhaps need to share with the public to understand that. And some of the things that we spoke about in the past, you know, simple things like, when was the last time you heard about virtual wards or virtual cares on any mainstream media program, be it EastEnders, Coronation Street, or anywhere? And, you know, just to start sharing that this is part of normal healthcare, that we can do things in the comfort of your own home. We can do it as, you know, a hospital at home or a clinic at home. And I also spoke to a colleague recently about, you know, how can we educate our forthcoming generations? And let's look at Lego. You know, we've got Lego hospital sets, we've got Lego GP sets. How many Lego sets do we have which have got little BP devices that you can build into the house to show our generation that actually you can also have healthcare within the home setting as well? So there are some real practical solutions that will take some real big thinking to put into place. But we need that narrative shift so that we're taking the public with us. But most importantly, the public need to be engaged. They need to be co-producing this with the health teams to make sure it is suiting their need. But we can only do that if the patient and the patients and the general public understand what it is that we're trying to achieve.
Really, I like the idea of little Lego monitors you can put into little Lego houses. Maybe we'll get in touch with them, see what they think. Stephen, did you do any, how do you change that narrative with the population you're looking after? Do you contact the local press to get people to talk about successful care at home, or is that something that your communications team are doing?
I don't think we've gone that far. I think one of the bits is where patients, again, it's a bit like clinicians, where patients have used it and found it really successful, is to use that voice, because again, I think there's something trusting about peer to peer. I don't think we've gone, I think we've got a lot more to do on it. So I think we've got a lot more to talk about the population, because I think, as Gernot was saying, alluding to, I think there's a slight nervousness that there's a feeling that you're missing out, almost like it's a secondary alternative to being able to see somebody. And I think we've had some really, really bad examples of media around primary care. So if you look at the numbers that primary care are doing in terms of just their activity, they are seeing far more people than they did pre-pandemic. But I would think if you listen to the media, and the perception of it is people can't get it, it's not happening. And I know there's a demand and capacity issue, but I just think that there is that shift. So we've gone at it very slowly, I would say, at the minute. But we have tried to do some, so we're trying to do some education with our patient groups and things like that. And actually, one of the bits that always comes through is most of us have watches that are measuring all sorts about us. There is a lot, actually, when we start to unlayer it, there is an awful lot that people have got and are getting used to, and it's trying to join the dots, I think, for some of that. You know, as Gernot, as you were talking, I was thinking that thing of we have used virtual medicine for a long time. I think they call it Google, and most people put the symptoms in and then come out with, oh, I'm dying within 48 hours or whatever, and use it. So I think we've just got to try and join the dots on some of it. But I think using people, I certainly had it when I was in acute when we set the COVID, we did it like a COVID virtual ward, which I think is where a lot of journeys started. And that patient to patient peer experience was really important. People got a lot of confidence from hearing somebody say, I was discharged, it went like this, it went really well, I didn't have to go into hospital. So I think the more we can kind of build on that, but I'm completely getting, there is a big mainstream thing we've got to do that we haven't quite tackled yet. We're thinking that through.
And I think as it becomes more embedded and you have more case studies, it becomes easier to talk of scale rather than the potential challenge of course, that one, you've highlighted the one or two cases that were really effective. What about scale? Scott, I don't know if you've come, I mean, you spoke a little bit about that education. What role does BT take? So do you talk about that, in terms of thought leadership? Is that something that you're putting out there, or is that very much for the clients to be leading, do you think?
I think it's probably for the clients to be leading. I mean, our bread and butter is communication and SMS, and I think it goes back to the original point: is at what point in the pathway do you begin to kind of educate and inform? It's the whole AIDA model of marketing: attention, interest, desire, action. So what are the right points that we should be beginning to educate and inform and give people not just the information but the tools by which to be able to self-service or use. So I think you can't really take one without the other. If you educate but you don't provide the tools to then act on that, then you've kind of missed out the what next, and all of a sudden it becomes knowledge which is resigned to history with patients. So there needs to be some level of follow-up.
Brilliant, thank you. I'm going to move us forward because I'm a little bit aware of time. How to optimize current system. I think this is sort of getting into the real practical for those who've dialed into this webinar today to take away some actual nuggets of what does good optimizing look like? Gernak, should we start with you? I'm going to, just so everybody get ready, I'm going to go Gernak, Eleanor, Stephen and Scott. That's my order. So Gernak, we'll start with you.
Yeah, thank you. I think in order for us to get the best out of the system, we need to recognise that the virtual wards part is part of the puzzle. And we have to start thinking bigger. We have to start thinking braver. And we have to start seeing virtual wards as a part of virtual care to have a real demonstrable impact on not just the system, but also on patients. That will really feed into what we've just been discussing, things like the culture change that's needed to drive this forward, things like the patient education and participation angle of things, and also making sure that our workforce is moving alongside with us. And I think if we can tackle those few things, and if we can really, really push to get the best out of our virtual ward systems, we can embed it as part of our, or one of the ways that we deliver care as a business as usual. And I think it's the key thing for me there is to think bigger than just virtual wards, think beyond virtual wards, and actually think beyond healthcare. We've moved into ICSs. Even though we have our ICPs within that and our ICBs within that, we need to be thinking broader. And I think it's with that we can start to optimize and get the best out of our current systems.
Brilliant. There's just a question in the chat that I'm hoping Eleanor or Stephen might be able to pick up as part of your comments, which is, how does this marry with existing community services? For example, hospital at home. So there's a terminology question there, but I mean, if there's a way that we can sort of pick up the answer to that in commentary, that would be brilliant. So Eleanor, over to you.
Well, no problem at all, because the note I'd written down was use what you have to start. So this is not about doing, new brooms sweeps clean and you stop doing everything else you've been doing. There's an awful lot of investment in technology in across ICSs and in organisations, and often organisations aren't entirely aware of the investment that's been made in technology, particularly as a result of COVID, because there was an awful lot of free good given to the NHS for all, great purpose at the time to help out. But now we're starting to see those technologies are starting to incur license costs, and people are wanting to scale. And so what I would say is use what you've already got in order to be able to scale at pace, but to be able to do that safely, where people have got confidence in systems that they've been using. But what's really important is to standardise wherever possible. So if you introduce complexity in terms of multiple systems and multiple pathways and multiple ways of doing things, it just drives cost and increases risk. So scale at pace safely and start by using what you've got. And then and picking up on Gernak's point as well, I'm really excited by this workshop this afternoon in Devon around virtual care and digitally enabled new care pathways, because we've got two different work streams. One is looking at the virtual hospital and the opportunities around virtual hospital and scaling virtual wards, and another area is around point of care testing and building the hubs. But we've also got virtual care, and we've got three pathways that we're going to be looking at, which is frailty, mental health and learning disabilities. And the redesign of those pathways is going to be led by social care. Now, there are three really challenging pathways that I think we've had lots of attempts at redesigning those pathways from health services, and we've ended up with a health model around frailty. But I'm really excited if we've got social care leading the charge around redesigning those pathways, we'll end up with really quite different solutions. So watch the space. I will come back and report on how things go. But it's exactly as Gernot was saying, we've got a real opportunity to join up health and care services.
Excellent, thank you, Eleanor. Stephen, is this similar to your experience? Use what you've got?
Yeah, so probably a couple of things to build on it, and probably for the question, because that was a very live debate for us and still is probably. So I described, we had a number of unplanned services that all had slightly different criteria and all had a slightly different name depending on the geography because of what we've historically done. And the danger was, and I think we were starting to do it, so the bit of learning that I got was that we were starting to do this, was we were then going to think of virtual ward as another layer, and we were going to layer that over again. Whereas, so we kind of paused and went, no, we've got to redesign all of it. So we built it into a kind of bigger redesign of our unplanned care services so that we can start to tackle that issue that I think's the question's getting at, because that was certainly live for us and it still is. We need to tackle that. Probably just a slightly different perspective, because I agree with everything that's been said, but one bit on not just building on what you've got, but how you think about it. So obviously I helped lead the board, and thinking about these services being delivered in this way is really different for a board to think through in terms of, you know, what challenges it can present for its governance, what we do, what work we've had to do with the non-executive directors to get them to think through, this will look really different and will not be a service that you traditionally will touch, as well as supporting the change programme that was going on in the board. So I think we did a lot of work talking that through with the non-execs and others, so that what we were able to do is provide that umbrella for the change to happen, rather than it get in the way of people suddenly asking a whole load of governance questions. We kind of did that up front. So that's just a different perspective on kind of taking it forward.
So that change management piece, really focusing on that and getting people comfortable. That's really interesting. And Scott, any thoughts?
I'll keep it uncharacteristically short. For me, it's around 3 buckets: control, convergence, and consolidation. So how do we begin to give more control to the NHS and the staff over its digital estate, over its data, over the applications that sit, especially when you start thinking ICB level? How do we consolidate the number of suppliers across the patch? So you start to consolidate, you can actually start managing bigger buckets of activity from a technology perspective. And then the final one's around convergence. So that's the convergence of data around the likes of command centers and optimizing the use of that data, but equally around solutions. So how do we think about connected ecosystems and reducing fragmentation, dropping virtual wards and virtual care into probably an already hectic IT environment, when you could actually link a lot of this together to really optimize? It's a hard job. You wouldn't want to eat the elephant whole, but again, it goes back to the point at the very start of the discussion around have an anchor and build out and test.
Brilliant. Thanks, Scott. And I don't know if anybody's got any other nuggets, because the last one we wanted to address was sort of one really practical piece of advice to improve or drive further adoption. And we may have covered that off, but I don't want to also take away the opportunity for the panel to give that final brilliant nugget that's going to really affect change in the trust in which you're working in. So Gernak, I'm going to go to you first. With your experience, what's the one thing, the practical bit of advice that if you've got lots of challenges, that you go, I'm just focus on this one, because this is the one thing that I really need to have my eyes on and make sure I solve. Oh, you need to come off mute. Is it come off mute?
Yeah, it put me on mute. Yeah, find your clinical champions, and really go with where the energy is. Everyone else will follow. I have yet to really see a virtual ward or virtual care model which isn't having a positive impact on patients, a clinical team, or a system. There are so many positives from this, and as others start to see that, it will start moving others alongside with that tide. So go where the energy is, find your clinical champions, embrace them, and be very compassionate in their approach to change and transformation.
Brilliant. Stephen?
Probably just following on that, I think you mentioned earlier about we get guidance around which pathways to do and which specialties to do. So as well as go where the energy is, be brave, and if we have to go somewhere slightly different but it achieves the result that we want, we go there. And I think that's for us as leaders to support clinicians to do that.
Excellent, thank you. And then Eleanor?
So I think mine would be to, because I've got courage as well, the same as everybody else. So mine would be to challenge the safety flag. So often we get the shroud waving around clinical safety in moving to these new models of care. Well, the evidence base is in some, if they're implemented well, are significantly safer models of care than the current model of care. So to challenge the safety flag and to make sure that you do implement obviously a safe service, but it's not necessarily that a digitally enabled virtual care service is less safe than the current service model.
And you've helpfully picked up one of the questions in the chat there, Eleanor, around safeguarding issues in virtual wards. So thank you. That was two birds, one stone. Scott?
I would say keep the end goal in mind. Have a bit of a systems thinking head, and this is just the start of the journey. It's not a siloed bit of technology. There's so much wider opportunity that sits off the back of getting this right and getting this done at scale.
Excellent. Well, we've got 2 minutes to go. I think we have picked up most of the questions in the chat and sort of just by dint of the conversation. So I think the takeaways are there's some really nice phraseology there, which is flavour of the month but tip of the iceberg, and I think we all agree that this isn't going away. So whilst there are some challenges around terminology, clinical appetite, it's for everyone as leaders to, as you say, Stephen, as leaders to go round those, because this is absolutely the model of the future and here to stay. It will enable the NHS to thrive, and there's enough, as we've also noted, when done well, the outcomes for both patients and clinicians are incredibly powerful. So I think that all that leaves me is to thank the panel very much for their thoughts and their time today, and also to thank everybody much for dialing in. Please do read the report. It's very interesting and expands on a lot of the themes we've spoken about today, and we'll also work out how to put the link to the first webinar in the chat, or to send that out as well. But thank you very much, everybody. Hope you have a good day. Thank you for dialing in. Bye then.
Thank you.